Good evening, everyone. So today I'm going to talk about malaria, a very important topic from the examination point of view, from the discussion point of view, and from the clinical point of view as well. Now look at the slide. Okay, there's a mosquito. You can clearly see it is trying to fly. So this picture depicts that mosquito is the vector of malaria. Now, which mosquito? We're going to talk about that. Definitely, it's anopheline mosquito, the female anopheline or Anopheles mosquito, isn't it? Let's move on to the topic. Now, malaria, okay, is a very common disease and it is affecting so many countries in the whole world, especially the tropical countries. But it is endemic in many different countries in the world. The meaning of malaria is foulier, okay. This is the literal meaning actually. It is a life-threatening disease caused by a particular parasite, and the name of that parasite is plasmodium. But plasmodium alone cannot cause the disease. We need a vector, and the vector is female Anopheles mosquito. So what is the meaning of that? The female Anopheles mosquito should carry that vector inside it, especially in the salivary gland, and when that female Anopheles mosquito is feeding on a human being, those plasmodium species would be injected inside the body, which leads to malaria. So from that discussion itself, we can plan for the prevention. So how can we prevent malaria? Nice. If we protect ourselves from the bite of that particular parasite, we can prevent malaria from the occurrence. Now, how many plasmodium species are there? Okay, 4 very common species and 1 recently found species. So those very common species are Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, Plasmodium malari, and Plasmodium knowlesi. The first 4 are relatively more common than the last one. Plasmodium knowlesi is recently found species of Plasmodium. Now, among them, Plasmodium falciparum infection is also known as malignant type of malaria. This is the most severe type of malaria, and invariably it is fatal type, and it is also resistant to standard chloroquine treatment. You already know from our pharmacology discussion, chloroquine is the drug of choice in the treatment of malaria. Okay, but not always. If there is Plasmodium falciparum malaria, we do not choose chloroquine as the first drug. You go for quinine or some other newly formed drug. Let's move on. Regarding the epidemiology of malaria, malaria is a very common disease all over the world, and it is one of the commonest cause of mortality as well, related to the infective diseases. Now see that approximately 1 to 3 million deaths occurs because of malaria all over the world per year, and uh, mostly the children are killed by malaria, especially in the sub-Saharan Africa, and in those places falciparum malaria is very common than other. Populations which are at increased risk for mortality due to malaria include high risk population, okay, like primigravida, okay, travelers without immunity, that means travelers who have not taken any chemoprophylaxis before they move on to the malarial endemic zone, or they had never malaria before, and young children aged 6 months to 3 years who live in endemic areas are also at high risk, probably because of decreased immunity. The antibody which they got from the mother already disappeared during that time, so they are no more immune. Okay. I already told you it's a very common disease all over the world. Okay, almost 300 to 500 million cases occurring annually or per year, and this is endemic in many different tropical and subtropical countries. There are some countries, okay, which are malaria free in the world as well, and they are usually the developed country because of the issue of sanitation. Okay, probably uh, the malaria, the mosquitoes, which are the vector of malaria, are not common there. So the incidence of malaria is also not common. Okay, now how malaria is transmitted? Now every student knows that it is transmitted by a vector, which is infected female Anopheles mosquito. Now that female Anopheles mosquito has to carry the pathogen inside it, and if that infected mosquito bite a normal human being, then disease can occur. Apart from that, malaria can also be transmitted in contaminated blood transfusions. Okay, meaning if we do not screen the blood for malarial parasite, then who knows, if that blood has malarial parasite, the person can be infected. It has occasionally been seen in injecting drug users also, who usually share the needles between them, and in a contaminated equipment which is used in the hospital can also lead to malaria. But these are very rare in comparison to the top two. Malaria is a very common disease in rainy season because of the stagnant water, okay, everywhere. That is a common or usual picture during rainy season. Okay, and malaria is quite common during that season as well. Now, there are certain protective factors in the host which are called innate immunity. Okay, because of these factors, those particular people are immune to malaria. Okay, now let's talk a little bit about them. The sickle cell trait, or also known as hemoglobin S. Okay, uh, in spite of normal hemoglobin, there is hemoglobin S present in those people. Thalassemia, okay, very important type of hemoglobinopathy. Hemoglobin C, and glucose 6-phosphate dehydrogenase deficiency or G6PD deficiency. These people are protected against the death from Plasmodium falciparum malaria. Okay, now the question is, why this occur? What is the reason behind it? And the reason may be because this Plasmodium falciparum malaria infect the normal RBC. All of those hemoglobin and RBC which are mentioned there are not normal, they're abnormal, isn't it? So probably the parasite burden in those abnormal RBC or hemoglobin is very less in comparison to the normal RBC. Individuals who have hemoglobin E may be protected against Plasmodium vivax infection. So this is important question in many different exams. These are called host protective factor. Now, before I move on to some other type of discussion, let me highlight one important point here. What do you think? After a patient gets malaria, okay, will that patient be immune to the future attack of malaria or not? Isn't this a very common query which comes in our mind? And the answer is yes, the person will be immune, but not completely. Okay, the person will definitely have certain immunity against the similar strain of Plasmodium, but not completely. Okay, that is a very important answer. Now, what is the incubation period of malaria? Now, different literature, they mention that the average incubation period is about 1 month, but it depends on different species of Plasmodium. Plasmodium vivax and Plasmodium ovale, They may emerge weeks to months after the initial infection. Okay, so it may be slightly longer. And one other important point is there is a high chance of relapse in these two species as well, and that relapse is mainly because of the hypnozoite stage which is present in both these species. That hypnozoite stage is present in the liver. Now, let's talk about life cycle of this Plasmodium species. Very important question for the undergraduate student. Now, this life cycle is completed in two different hosts. Okay, one is human being, another is mosquito, and accordingly, two different terms are used. One is called definitive host, another is called intermediate host. Now, can anyone tell me what is the difference between these two terms, definitive host and intermediate host? Definitive host means where the sexual life cycle occur, and intermediate host means the sexual life cycle doesn't occur, means other parts of the life cycle occur. So it is definitely human being which is the definitive host in case of malaria. Let's talk about life cycle. The female Anopheline mosquito becomes infected after taking a blood meal which contains gametocyte, and the name itself suggests gametocyte are the sexual form of the malarial parasite. And I already told you these gametocytes are formed inside the human being. And after the female Anopheline mosquito, okay, takes a blood meal from that infected human being, this gametocyte will enter into the mosquito. Okay, the developmental cycle in the mosquito after that usually takes about 7 to 20 days. Okay, it depends on the environmental temperature, and after that, when that cycle is over in the mosquito, sporozoites would be formed, and these sporozoites are mainly haploid in nature. Okay, and they migrate to the salivary gland of that mosquito. Means that mosquito is ready to infect another person. Now, the sporozoites are inoculated or injected into a new human host, and those which are not destroyed by the immune response are rapidly taken up by the liver. I like to highlight this sentence a bit here. The sporozoites which are inoculated or injected by the mosquito, okay, they remain in the skin for a few hours. Up to 6 hours they remain on the skin or at the bite area. Now from there, okay, some of the sporozoite would migrate onto the lymphatics and into the lymph node, and some other sporozoite will migrate into the bloodstream and then reach the liver. Okay, so inside the liver they multiply inside the hepatocyte. Okay, hepatocytes are the cells of the liver, isn't it? We all know that. So inside the hepatocyte they multiply and they come out as a merozoite stage. Okay, and where they go now, from the liver they'll enter into the bloodstream and they infect the RBC. Now this all a cycle inside the liver which occurs before the erythrocyte cycle. So it is called pre-erythrocytic or hepatic sporogony. That's why the name has been given, pre-erythrocytic or hepatic sporogony. Now, after a few days, the infected hepatocyte rupture. I already talked about this. Okay, this is a bit of revision for you. Now, those hepatocytes, they rupture by the infected, organisms, and they release merozoites into the blood, and then those merozoites will enter into the RBC or erythrocyte. Some of the parasite from Plasmodium vivax and Plasmodium ovale, they remain as a dormant form. Dormant means latent form in the liver, which is known as hypnozoite. Hypno means sleep. So they are in the sleeping state. Hypnozoites, very easy term to remember. But remember, Plasmodium 5x and the oval are the only two species of Plasmodium which results in hypnozoite, not the other type. Okay. Now, I like to highlight a few of the cases which have occurred in Ichun. Some of our medical students, they have developed malaria in Ichun, China, and we all know malaria is not very common there. So the question comes, then how did they develop malaria there? What may be the mechanism? The mechanism is very nicely described here. This is called relapse. Okay, relapse of malaria. Probably in the past they had episodes of malaria. Okay, and those organisms, maybe vivax or oval, they are in the hypnozoid stage, and they may reactivate it right now, resulting in malaria. Now let's talk about what happens inside the red blood cell. Now, inside the red blood cell, those parasites, they multiply, okay, and they go in a different developmental stages. From the merozoite, remember when they enter into the RBC, they are in the merozoid stage. Now they develop the schizont. Schizont means they look like a big cell, and inside this big cell there are so many different types of pathogens there. Okay, some of them would also develop into trophozoite. Okay? Now, when that schizont rupture, around 8 to 24 new merozoites would come out from there, and when they come out, they would infect other new RBC or other healthy RBC. This is how the disease will progress there. Okay. Now, each cycle of this process is known as erythrocytic schizogony. Erythrocytic schizogony, which takes about 48 hours in Plasmodium falciparum, vivax and oval, and about 72 hours in Plasmodium malariae. That is the reason why the fever also takes this long time or this long hours to develop. For example, we talked about intermittent fever. Okay, intermittent fever in case of malaria, isn't it? Those intermittent fever takes 48 hours or 72 hours uh, to develop. Or let me clarify this in other way. There is a big gap between two episodes of fever in case of malaria. In falciparum, vivax and oval, that gap is around 48 hours or 2 days, and in plasmodium malaria, the gap is around 3 days or 72 hours. Okay, this is very important knowledge. Now, Plasmodium vivax and Plasmodium oval, they mainly attack the reticulocyte and young erythrocyte, whereas Plasmodium malariae tends to attack the older cells or the mature RBC, whereas Plasmodium falciparum, the most severe type of Plasmodium, will parasitize or infect any stage of the erythrocyte. So probably because of that single reason, Plasmodium falciparum is the most severe type of malaria, because it is damaging or destroying any stage of the RBC. Now, let's revise all those things which we have discussed till now with the help of this diagram or a flowchart. Okay, you can see here very clearly. This is developed by CDC or Center for Disease Control. Okay, now see here. Let's start from the mosquito. Okay, number one, the mosquito. Which mosquito is this? Female Anopheles mosquito. It takes a blood meal. Okay, it takes a blood meal. This mosquito is already infected mosquito, right? Isn't it? It's an infected mosquito. So if this infected mosquito, let's see here, inject the sporozoite, right? It injects the sporozoite. These sporozoite are the infective form of malarial parasite. The I is written there. This is the infective form. Now, for few hours, for up to 6 hours, they may remain on the skin, and some of them will migrate onto the lymph node, and some of them will migrate into the blood and then reach the liver or into the hepatocyte. Inside the hepatocyte, they'll multiply. Okay, those hepatocytes will rupture, isn't it? Rupture. Okay, this stage is called schizont. Okay, hepatic schizont, and after the rupture, many merozoites will come out of the ruptured hepatocyte and again enter the blood. The stage before the erythrocytic stage is also known as exoerythrocytic cycle or hepatic cycle, or we call it hepatic schizogony. There are different terms. Now, I like to highlight some of the point here. In Plasmodium ovale and Plasmodium vivax, okay, some of these parasite will remain there for a long time as a hypnozoite, and later on, after many years, okay, they may relapse to cause the disease again. Now, let's talk about RBC cycle. This is known as erythrocytic cycle. You can see right here. Okay. Now these merozoites, they'll enter into the RBC. Okay. They'll develop into the different forms now. Some are called trophozoite or ring stage. Okay. Isn't it? Here they develop into the mature trophozoite form. Okay. In another stage, they develop into schizont. Okay, schizont is a big type of cells. Inside them, many different cells are there. This schizont will rupture, and again, many merozoites will be released, and these merozoites will infect the other normal RBC. Some of the merozoite, okay, some of the merozoite or even the trophozoite, it can be anything, can develop into the gametocyte. Okay, gametocyte. Now, this gametocyte will travel or circulate in the blood. Now, it takes time to form these gametocyte. In case of Plasmodium falciparum malaria, okay, or Plasmodium falciparum organism, okay, it almost takes 7 to 15 days to develop this gametocyte. But in case of Plasmodium vivax, especially, the vivax is another common type of malaria, it can develop even before the clinical features. So that is quite an important point regarding clinical point of view. Now, you may be wondering when the typical fever of malaria occurs, in which cycle or which phase. This typical fever always occurs in this erythrocytic cycle, not in the exoerythrocytic cycle. So, it depends on the periodicity of a particular organism. Periodicity means what is the gap between each episodes of the fever. Okay, that gap is 48 hour or 72 hour. Now we are in the gametocyte phase. Now what happens? This gametocyte, okay, are the sexual forms of the parasite. Now these sexual forms of the parasite would be taken by a mosquito, okay, which takes a blood meal in that infected person. So these gametocytes will be ingested by that female anopheline mosquito. Now the cycle starts inside the mosquito. Okay, inside the mosquito, they develop into a bigger type of gametocyte. Okay, bigger type of gametocyte, and then those microgamete entering into the macrogamete now, and they form ookinete. Okay, from the ookinete they form oocyst, and inside the oocyst you can see there are so many pathogens, and then this oocyst will rupture, which release sporozoite. These sporozoite are the haploid form of the parasite, and these are also known as the infective form of the parasite. And then when this mosquito bites another person, this sporozoite will be injected, and the same cycle will repeat once again. So this is how the life cycle of malarial parasite would be discussed. Okay, now see here, I means infective stage and D is a diagnostic stage. Very common question will be asked in different exam. Now, from this diagram, what is the infective stage? It's sporozoite. What is the diagnostic stage? So many. Okay, see this? Look at the letter D here. This trophozoite is also a diagnostic stage. This ring stage is a diagnostic stage. Schizont is a diagnostic stage. Okay, gametocytes are the diagnostic stage. So many different diagnostic stages are there. So whenever we take a blood from the suspected patient, if we see these diagnostic stages, okay, and the RBC, that's how we diagnose malaria. Another common question which will be asked to you is, how can we break this life cycle? Okay, see here, we can break the life cycle if we don't allow those mosquito to bite us. Very easy answer, but difficult to do, isn't it? Difficult to do. Okay, easy to say but difficult to do. If it is easier to do, nobody in this world would die or suffer from malaria. Another one, with the help of medicine or the drug, okay, if we kill this pathogen right here in the erythrocytic stage, these gametocytes are killed, or these schizons are killed, then probably the cycle will be broken. Now let's move further. There are some terms regarding the malarial infection. These are called recrudescence and the relapse. Okay, what do you mean by that? Recrudescence means this is an exacerbation of persistent, undetectable parasitemia. Now, let me describe this in a very easy way. This person has got malaria. Okay, so to have malaria, the person should have parasite in the blood. The person should have erythrocytic cycle. Now, what happens? Somehow, maybe because of the use of medicine, okay, or because of the good immunity, the number of these parasites are very less. They almost become undetectable. Okay, so the person, it looks like the person is free of malaria now. Suddenly the same person will develop fever again. This is called recrudescence. The disease has not disappeared from the blood or from the body, and somehow the disease severity, okay, has come back. This is recrudescence, and this occur due to survival of erythrocytic forms, okay, and there is no role of any exoerythrocytic forms in this condition. So the common organism where recrudescence occurs are falciparum and malaria. What about relapse then? Now remember, relapse occurs in Plasmodium vivax and Plasmodium ovale, and in these forms, hypnozoite stage exists in the liver. So if hypnozoite is reactivated, then second episodes of malaria can occur in them, which is called relapse. Recrudescence and relapse. Recrudescence usually occur in falciparum and malaria, and relapse usually occur in vivax and ovale. Mechanism is different. Now, how these parasite damage our cells, especially RBC? What they do there? Okay, this is called pathophysiology. So there are three important terms which you can see there. These are called cytoadherence, sequestration, and rosetting. Let's talk a little bit about them. Cytoadherence means after about 24 to 36 hours of merozoite infection, those infected RBC or erythrocyte become sticky due to appearance of a knob-like structure on the surface, okay, and they can adhere themselves to the venular and capillary endothelium. Means they get stuck on the surface of the blood vessel. This is called cytoadherence. Another important term or mechanism is called sequestration. The sequestration means a hidden form. These forms or these infected erythrocyte, okay, they become disappeared from the circulation, and it occurs in the venules of brain, heart, liver, kidney, and intestine. So there are many different organs take active role in disappearing this particular infected RBC. Rosetting is another mechanism. That means this infected erythrocyte also adhere to the uninfected erythrocyte. Okay, this infected erythrocyte also adhere to the uninfected erythrocyte, so that those uninfected erythrocytes are very easily infected now, and at the same time all of these may be ruptured together. And this rosetting is very prominent in cerebral malaria. Cerebral malaria usually occur in falciparum type. Now, after doing all this pathophysiology and life cycle, let's talk about the clinical features of malaria. Okay, the normal incubation period is roughly 1 month, but some of the textbook can mention it around 10 to 21 days also, but it can be even longer than that. So you can remember around 1 month. So there are different stages, a different way by which we can discuss the clinical features, like clinical feature of uncomplicated malaria, clinical features of severe complicated malaria, also known as malignant malaria or falciparum malaria. What happens in congenital malaria? What are the chronic complications of malaria? And what do you mean by relapse and recrudescence? The last two terms we have already discussed. So remaining terms or stages we are going to talk one after other. The classical symptoms, or clinical features of malaria are anorexia, malaise, irritability, headache, myalgia, and slight fever in the beginning. And it is very difficult to diagnose malaria because of these symptoms. So we can also call them non-specific symptoms here. This is followed by the classical paroxysm of malaria, which are cold stage, hot stage, and sweating stage. Cold stage means stage of chill. Chill means the person feels very cold. Hot stage means high grade fever would be there. And sweating is a defervescent stage. Now the severe sweating in the patient and the temperature rapidly decreases. So this is a classical paroxysm of malaria. Apart from that, some other findings are also very important, like palpable spleen, which is called splenomegaly, palpable liver, which is hepatomegaly, anemia. Why anemia occurs? Every student can answer this, because one of the stage of life cycle occurs inside the RBC, and these RBCs are ruptured or destroyed in case of malaria. And if these RBCs are ruptured or destroyed, there will be jaundice as well. This is called hemolytic jaundice. Now see here, these three stages are highlighted once again: cold stage, hot stage, and sweating stage. The cold stage, the stage of chills, the temperature is slowly going higher and higher here. The person feels intense cold, and the person may shiver as well. These are called chills and rigor. Shivering is called rigor. The person may clench the teeth and shiver, and feeling of cold is called chill. Usually in this phase, vasoconstriction occurs in the body. So when you touch the patient feels cold. This is followed by hot stage. There's high grade fever now. Usually the fever goes up to 39 degree, 40 or even 41 degree. Along with that, there's severe headache, myalgia, vomiting, fast respiration, which is called tachypnea, palpitation, as well as delirium. Now, delirium means acute confusional state because of high grade fever. in this condition. Okay, there are so many other causes of delirium. Let's not go into the detail here, but high grade fever can also result in delirium. Now the last stage is called sweating stage. This hot stage is followed by sweating stage, and in this stage there is drenching sweat. The patient is pouring with sweat here. Okay, and with this there is a rapid fall in temperature. It may take around 2 to 3 hours for the defervescence. Now, what type of fever is there in malaria? This is called intermittent fever. Okay, intermittent fever, and you already know what is the meaning of that. Intermittent fever means there is a gap between two episodes of fever, and okay, and there is a fever free period in between that. That is called intermittent fever, and that a gap may be 48 hours or 72 hours. Okay. Torsion or quartan fever. Torsion fever is seen in falciparum, vivax and ovale, and quartan fever is seen in malaria. Okay, but one important point I like to highlight here: this periodicity or gap of the intermittent fever is not that very common these days because of the routine use of antipyretic drug, isn't it? Every person who is having fever will use antipyretic drug. So after that drug is used, probably this type of periodicity may not be very apparent. Now, plasmodium vivax and plasmodium ovale, it may lead relapse of the infection, or sometimes even the symptoms can occur very late. Okay, so this is an important point we should consider in the history taking, especially in vivax and ovale. Travelers who travel to Southeast Asia, okay, especially in Malaysia, or sometimes in some South American countries as well. These days they have been infected by Plasmodium knowledge, which is a relatively a newer species in Plasmodium. Okay, and this Plasmodium knowledge is endemic in long-tailed and pigtail macaque monkeys. So these are the host for these parasite. Okay, probably in the past these parasites were mistakenly classified as some other forms, but these days they have identified this as the newer one. And what is the severity of this Plasmodium knowledge? Now, according to the severity grading, this comes just after the Plasmodium falciparum. So it is considered as a quite a severe type of malaria. Now, those are the clinical feature which we have discussed till now. They are very common in vivax, okay, ovale or malaria. But what about falciparum, which is the most dangerous or most malignant or lethal type of malaria? Look at this list. So many different organs are affected, right from central nervous system, okay, to gastrointestinal system, as well as some other manifestation. So in central nervous system, they cause cerebral malaria. Okay, cerebral malaria. The cerebral malaria is an important differential diagnosis of bacterial meningitis and as well as encephalitis. So patient may develop coma as well as convulsion along with some focal neurological sign. We'll talk about that. In the renal system, they may lead to black water fever. Okay, that's black water fever is because of hemoglobinuria. Now, why hemoglobinuria occurs in this condition? Just think about it. Your answer is right there. Remember, because of erythrocytic cycle, there is rupture of the RBC and hemoglobin will be released or liberated. It will be free hemoglobin, which will be filtered by the nephrons, and this hemoglobin will appear in the urine, leading to black water fever. Oliguria because of renal failure, as well as uremia. Uremia means there is increased blood urea nitrogen and serum creatine in the blood. This may be a feature of acute tubular necrosis, okay, which is a type of renal failure. In the blood itself, they can lead to severe anemia because of hemolysis as well as erythropoiesis, and they may lead to disseminated intravascular coagulation, DIC, which is a very fatal condition. In the respiratory system, they can lead to ARDS, okay, acute respiratory distress syndrome, also known as non-cardiogenic pulmonary edema or shock lung. Different terms are there. This is a very serious condition and patient may die because of hypoxia. And only one treatment can save this type of people, that is ventilator therapy, along with which disease is causing that, we should go for the treatment. What are the metabolic feature of severe falciparum malaria? They are hypoglycemia and metabolic acidosis. Okay, hypoglycemia and metabolic acidosis. Metabolic acidosis is very common. Regarding the GI tract and liver, diarrhea, jaundice, and rupture of the spleen are also very commonly seen, and some other which were not, discussed in any of the above headings are shock, that is hypotensive shock, also known as septic shock, as well as hyperpyrexia, that is high grade fever. This high grade fever itself can lead to a lot of problems. So because of these complications, falciparum malaria is also known as malignant type of malaria or a very severe type of malaria. Okay. Now, I have divided this topic of malaria into two halves. Okay, this is the first half, and the second half will be discussed tomorrow. So after going through this slide, please solve these questions, and if you can confidently solve this, okay, then you know you have done well in this half discussions of malaria. So I advise you to wait for the another half in another discussion. Thank you so much. Hello everyone. So good evening. So today I'm continuing part 2 on malaria discussion. So last time we talked about the life cycle of plasmodium, the different species of plasmodium. Along with that, we also talked about clinical features of malaria. What are the common clinical features of uncomplicated malaria, and what happens in case of complicated or severe malaria, which is caused by Plasmodium falciparum. Okay, so today we mainly focus on those complications, some of the discussions regarding those complications, then how to diagnose a case of malaria, what are the investigations you like to order, and then the management. Now, see here, these are some of the features of severe falciparum malaria. In the first part of malaria discussion, I already talked about this. This is just a repetition of the same slide. In the central nervous system complications, there is cerebral malaria. Okay, very important complication of falciparum malaria. In renal problems, we have black water fever. This is just another name for hemoglobinuria, oliguria or renal failure, as well as acute tubular necrosis. In blood, there is severe anemia because of hemolysis, and there may be DIC as well. In respiratory system, there are ARDS, acute respiratory distress syndrome, which is also known as shock lung. It can kill the patient easily. In metabolic complication, there is hypoglycemia, which is particularly common in children, as well as metabolic acidosis. Different reasons for that. Okay, and others important one are shock, that is hypotensive shock, or maybe because of algid malaria, or high grade fever because of hyperpyrexia. Now let's start with cerebral malaria. Now, in cerebral malaria, there is high grade fever, and that patient usually presents to the hospital with coma and seizure. But there are so many other causes of coma and seizure along with fever. Okay, so how to know this is a case of cerebral malaria? So for that, WHO or World Health Organization defines cerebral malaria as a clinical syndrome which is characterized by coma at least 1 hour after the termination of a seizure. Coma at least 1 hour after the termination of seizure, or correction of hypoglycemia. Along with that, asexual forms of the plasmodium falciparum should be present on the peripheral blood smear, and there should be no other causes of coma in the patient. Okay, so there are three important points here. Coma at least 1 hour after the termination of seizure or correction of hypoglycemia, asexual forms of plasmodium falciparum present in the peripheral blood, and there is no other definable cause of coma. This definition is important one because there are so many other causes of fever with seizure as well as coma. Okay. Now, what will be the pathogenesis of cerebral malaria? Now, pathogenesis of cerebral malaria is similar to pathogenesis of any other severe type of malaria. In this case also, our brain, okay, the microcirculation inside the brain or cerebral microcirculation, okay, are filled up with parasitized RBC, or in other words, these parasitized RBC means those RBC which are carrying plasmodium falciparum inside are sequestered, or these RBC they hide inside the cerebral microcirculation, and as a result of this, there may be decrease in blood flow to different parts of the brain. Okay. At the same time, because of intensive inflammation, there will be release of different cytokine. These factors are mainly responsible for cerebral malaria. Now, I've already mentioned in cerebral malaria there is high grade fever followed by seizures and coma. This is how the patient presents to the hospital. This is quite common in children, especially in sub-Saharan African country. Okay, this is more common there, and mortality rate reaches almost 15%. And these patient, they may present to the hospital within 1 to 3 days of onset of the fever. Along with them, the neurological signs in cerebral malaria are raise ICP, very important one because brain is affected. Okay, there will be cerebral edema, so increase or raise intracranial pressure is quite common. There is variable muscle tone. Usually the muscle tone may be hypertonia. Okay, there will be absent abdominal reflex. This is a feature of upper motor neuron lesion which is happening in case of cerebral malaria. Upgoing plantar, also known as Babinski sign, quite common here. Opisthotonous position because of extreme rigidity. Decerebrate or decorticate posture. Okay, look at this picture here. This is decorticate posture and this is decerebrate posture. In decorticate posture, the upper limbs are flexed. Okay, only lower limbs are externally rotated and extended. But in decerebrate posture, all four limbs would be extended and rotated outside. This is called opisthotonous position. Okay, opisthotonous. Tetanus is another disease which may present in the same way. Now, along with them, cranial nerve abnormalities may be there. Any of the cranial nerve can be affected. There may be involvement of the retina, which results in retinal hemorrhage, and there is disconjugate gaze as a result of involvement of the extraocular muscles. Again, those extraocular muscles are involved because of damage of the third, fourth, and sixth cranial nerve. Now, one point I like to highlight here, even if this child or this patient survive, they may have many neurological sequelae later on. Okay, some of them may have persistent neurological sequelae even after the treatment of the disease. So cerebral malaria is considered a very important complication of falciparum malaria. Now, second important complication is severe anemia. Now, this severe anemia can lead to high output cardiac failure and even the death. Now, the question is why this anemia occurs in this condition. It occurs because of hemolysis of infected red cell. Now, let's go back to the pathogenesis. What is happening inside the RBC? Especially in falciparum malaria, this plasmodium falciparum is a type of plasmodium which affect all types of RBC, whether they are young or mature. So if they are infected, they will get ruptured, and that is called hemolysis. Now, even the non-infected red cells will be ruptured in this case. There will be rosetting, there will be cytoadherence, and then all these affected RBC may be ruptured. Sometimes they get stick to the normal RBC, and the whole the complex may be broken, resulting in severe hemolysis, and that can result in hemoglobinuria, which is called black water fever. Dyserythropoiesis can occur. What is the meaning of dyserythropoiesis? The bone marrow may get suppressed. So bone marrow may not produce enough RBC, which contribute to anemia. Splenomegaly is a very common feature of malaria, and when spleen is big, that spleen can consume a lot of RBC. In other words, RBC may be sequestered inside the spleen. That may help in anemia and folate depletion. Remember, this is a type of hemolytic anemia. In hemolytic anemia, the bone marrow is trying to work harder than before. So it needs a lot of different substance to have more synthesis of RBC, and folic acid is one of them. So folic acid may be depleted, which further contributes to anemia. This is a very important question, so please revise this many times. Now, black water fever is another important complication of falciparum malaria. Black water fever means the urine is high in color, or you can say urine is a little bit dark in color, or Coca-Cola in color. This occurs because of hemoglobinuria. Now, why hemoglobinuria occurs here? Because of massive intravascular hemolysis. Now, we can easily explain this by infection alone. Severe falciparum malaria alone can lead to black water fever, but it can also occur if we use primaquine or quinine type of drug, which are called oxidative drugs, in case of G6PD deficiency patient. So for example, if this patient is having malaria as well as G6PD deficiency together, and if we are using this oxidative drug during the treatment, then there is a high chance of hemolysis, hemoglobinuria, and black water fever. Another one is hypoglycemia. Now, what may be the mechanism for hypoglycemia in this case? The mechanisms are quite nicely written there. This is mainly because of suppression of gluconeogenesis, and this suppression is induced by cytokine. This is an inflammatory disease, so there is a liberation of cytokine in a large amount, which may suppress gluconeogenesis. And I'm sure every student know what is gluconeogenesis. This is a synthesis of new glucose in the liver. If this is suppressed, then there is a high chance of hypoglycemia. Another factor which contribute in hypoglycemia is increased glucose consumption, either by the parasite, or because of high metabolic state, our body may also consume more glucose. The third important reason of hypoglycemia is if we are using quinine in the treatment, this quinine can stimulate pancreatic insulin secretion, and insulin is hypoglycemic hormone. So all these factors can result in hypoglycemia. So remember, this is important point during the management. So a patient with severe type of malaria can be hypoglycemic. So we need to think about it and then do appropriate management during the treatment. Another important complication is known as algid malaria. Now this algid malaria is the term we use for, okay, if this type of patient develops shock with cold extremity rather than warm extremity, it is called algid malaria. And this occurs because of secondary gram-negative bacteremia as well as septicemia and hypotension. So let me revise once again. In many cases of severe malaria, the patient is quite warm to touch. But if this patient is quite cold when we are examining, along with that, if this patient is having hypotension or low blood pressure, okay, then this may be a case of algid malaria. And this is usually occurring because of secondary gram-negative bacteremia as well as septicemia. So we need to include broad spectrum antibiotic if you suspect it. Now, what is congenital malaria? Okay, we have listed congenital malaria as one of the clinical manifestation of malaria. Now, the name itself suggests congenital malaria is malaria present at the time of birth, and of course, this malaria comes from the mother. The symptomatic congenital malaria is quite rare due to transplacental transfer of protective maternal IgG antibody. So it's not that common as other manifestation of malaria because of maternal IgG antibody. Okay. In endemic area, it is a cause of abortion, stillbirth, premature birth, as well as IUGR. So a lot of complication can occur because of congenital malaria. The baby may be aborted quite early. Even if the baby is still there, then the baby may be born in a dead state, which is called stillbirth, premature birth, as well as intrauterine growth retardation. If we examine placenta in congenital malaria, it may look black due to malarial pigment. And one of the important point here is, if this congenital malaria is caused by plasmodium 5x and ovale, there is no exoerythrocytic cycle or stage. Remember, yesterday we talked about this. Because of this, there is hypnozoite stage in 5x and ovale. But in this case, there is no exoerythrocytic stages, so there is no hypnozoite stage present. As a result of this, primaquine treatment is not necessary in congenital malaria. Now, there are some chronic complications of malaria, which are tropical splenomegaly syndrome as well as nephrotic syndrome. Nephrotic syndrome you have discussed so many times before. Okay, so no new knowledge there. Tropical splenomegaly syndrome. Okay, what is this? Now let's talk a little bit about it. Tropical splenomegaly syndrome means there is a massive splenomegaly in the patient, and this massive splenomegaly, when we examine it, it crosses the umbilicus level. Okay. Now remember, spleen always enlarge towards the right iliac fossa. So when we are examining spleen from there, when we reach the umbilical level, the tip of the spleen may be palpable. This is called massive splenomegaly. One of the causes is tropical splenomegaly syndrome, or you can simply say chronic malaria. This occurs because of constant stimulation of reticuloendothelial system of the spleen by circulating antigen-antibody complex. Even hepatomegaly may be there along with splenomegaly in this case. Okay, there are some important points for the diagnosis of tropical splenomegaly syndrome, and those are: the patient should be a resident in malaria endemic area. Okay, during examination there is massive splenomegaly, there may be hepatomegaly with elevated IgG and IgM if we measure those immunoglobulin level, and if we take a biopsy from the liver, there is usually Kupffer cell hyperplasia. These Kupffer cells are called macrophages, which are present inside the liver. Now, how we confirm the diagnosis of malaria? For example, if a patient comes to the hospital with fever, with chills and rigor, okay, you may suspect this may be a case of malaria. But how to confirm it? Let's talk about this. In returning travelers from the endemic area, for example, okay, you are visiting those endemic area, okay, from those countries which are not endemic regarding malaria, then malaria is suggested by the triad of thrombocytopenia, okay, elevated LDH level, and atypical lymphocyte. Now, this is an indirect clue for the malaria. If these features are there, then the next step for me is examination of peripheral blood smear for malarial parasite. Blood culture is usually done if a patient presents with high grade fever and chills and rigor. Okay, malaria is just one of the differential diagnoses. There may be so many other. So never buy stop during this type of presentation. You should always send blood culture in the patient. You should do CBC, and hemoglobin is one of the important part of that. Remember what happens to hemoglobin in case of malaria? It is decreased, isn't it? It is decreased. And what's the reason? Mainly because of hemolysis. It is decreased in 25% of the patient and often profoundly decreased in young children. Platelet count, we already talked, it's decreased in 50 to 68% of the patient, okay, quite common. And liver function tested abnormal in almost 50% of the patient. So this is an important type of investigation which will give us a clue this may be a case of malaria. Apart from that, we need to do renal function test, serum electrolyte level, okay, and haptoglobin, LDH, and even reticulocyte count. Now, renal function, we can easily give explanation here. Why renal functions are important? Remember about hemoglobinuria. Remember about acute tubular necrosis. Remember about renal failure in a case of malaria. Okay, and regarding electrolyte, if renal failure is there, electrolytes are always seen during investigation because they may be altered. Haptoglobin, LDH, and reticulocyte count are a very important investigation in case of hemolytic state, and malaria is one of the cause of hemolytic anemia. Rapid HIV testing may also be indicated in selected cases. Okay, if you suspect high risk factors, then even HIV testing should be done. Okay, now fewer than 5% of the patient with malaria have an elevated white blood cell count. Just fewer than 5%. Otherwise, white blood cell count may be within normal limit or maybe even less. Another important point, okay, is regarding the treatment. If we are going to treat this patient with chloroquine and primaquine, then the G6PD level should be obtained, especially in male patient, because G6PD deficiency occurs as a X-linked recessive way. So male are the usual patient here. Okay, so if we are planning to use primaquine, then it should be assessed. Otherwise, severe hemolysis may occur in this patient, which may contribute in black water fever. Now, if you suspect the patient is having cerebral malaria, now small question again, how cerebral malaria is suspected? Very good. If the patient presents with high grade fever, seizures, and in unconscious state. We should always obtain a blood glucose level to rule out hypoglycemia as a cause of mental status change. Remember the definition of cerebral malaria. World Health Organization has clearly stated that hypoglycemia must be ruled out then only you can label this patient as cerebral malaria. Another important point, if we are going to use quinine or already use quinine, then blood glucose should always be monitored because quinine can lead to hypoglycemia. For the definitive confirmation of the diagnosis, we should go for blood smear, that is thick and thin film or smear. Okay, thick film should be stained with Giemsa or field stain, and thin films with Giemsa or Leishman stain. Similar type of stain there. There is nothing to worry, but thick and thin both are done for the confirmation of diagnosis. Now, one common question you may get: why thick and thin films are here? Thick, okay, is done for confirmation of the malarial parasite, and thin is done for which malarial parasite is responsible. Is it Vivax? Is it Falciparum? Is it Ovale? Is it Malaria? Or is it Knowledge? So these are the differences. Some other investigation can be imaging study, okay, like chest X-ray or CT scan of the head. If a patient is having respiratory symptom like ARDS, okay, then chest radiography is always done. And if a person is having cerebral malaria, the person is in coma or seizure, then CT scan of the head can be done just to rule out whether there are other causes of coma or not. PCR or polymerase chain reaction can be done if the diagnosis is difficult. Okay, so even with a very small number of parasites present in the blood, PCR can give us the diagnosis. Don't forget to do lumbar puncture or CSF analysis in a case of suspected cerebral malaria. This really helps in the diagnosis. It can also help to rule out bacterial meningitis as the cause of coma as well as seizure. Now look at this slide. Okay, look at this slide. This slide really helps us in the diagnosis of malaria. This is the ring stage. Okay, ring stage is also known as trophozoite. Trophozoite stage looks like a ring stage. These are the gametocyte. Okay, if this type of appearance seen in the peripheral smear, without any doubt, we make a diagnosis of malaria. See here, this ring stage is called trophozoite stage. Now again, there are different trophozoite forms here. See here, most of these are ring-like appearance. Okay, trophozoite form. This is called schizont. This schizont means this is a large type of collection with lots of merozoites there. This schizont will rupture and release numbers of merozoites outside the ruptured RBC, and then these unaffected or even the normal RBCs would be affected. See that schizont again. Okay, inside the schizont, these merozoites are developing. Now we have reached to the final part of the discussion, that is the treatment. Now regarding the treatment, always, okay, even though it is not written like that in the slides, never forget the basic things. Treatment can be definitive treatment as well as supportive or symptomatic treatment. Almost all the disease, whatever we discuss, can be done in this way. The following is a summary of general recommendation for the treatment of malaria. In Plasmodium falciparum malaria, these days, chloroquine is resistant in most part of the world. So we usually go for quinine-based therapy. Okay, quinine-based therapy. We may use some other drugs along with quinine, like doxycycline or clindamycin or pyrimethamine and sulfadoxine combination. Some alternative therapies are also there, like artemether and lumefantrine combination, atovacone and proguanil combination, or simply mefloquine. So these are some of the alternative. But usually in many hospitals in the world, They start with quinine along with doxycycline or clindamycin, or they can go for artemether and lumefantrine combination. Now, Plasmodium falciparum malaria with non-chloroquine susceptibility. Only a few areas in Central America and the Middle East, okay, are still having susceptibility of Plasmodium falciparum to chloroquine. You use chloroquine in that case, but okay, uh, in other parts of the world where we already know Plasmodium falciparum is resistant to chloroquine, please don't take any chances. In Vivex and oval malaria, chloroquine must be combined with primaquine. Now, a common question would be asked here, why primaquine? Why not chloroquine alone is enough? And the answer is, in Vivex and oval malaria, there is high chance of hypnozoite formation inside the liver. Those hypnozoites are responsible for relapse of malaria later on. So, to kill those hypnozoite stays, you must use primaquine for almost 14 days. In Plasmodium malaria, chloroquine alone may be enough, and in Plasmodium knowlesi, recommendations are same as those for Plasmodium falciparum because it is considered severe type of malaria. Now, what about in pregnancy? Okay. Remember, primigravida are very commonly affected by malaria in the endemic area. So what we do if a pregnant lady is having malaria? The medication that can be used for the treatment of malaria in pregnancy include chloroquine, quinine, atovacone proguanil combination, clindamycin, and mefloquine. Okay, mefloquine should be avoided in first trimester. We can use sulfadoxine and pyrimethamine combination as well, but this is also avoided in first trimester. And you can also go for artemisinin combination. Now, there is not much difference between the treatment of malaria in pregnancy and in non-pregnant or other type of patient. Only some exceptions are there, like those drugs which are mentioned. It should be avoided in first trimester. Now, what are you going to do if a patient is admitted in the hospital? What type of inpatient care you provide? If this patient is having cerebral malaria and if this patient is in coma, okay, you care for coma just like any other patient. If this patient is having repeated seizure attack, then you give anti-seizure medicine. Okay, so you can discuss like that in the general management of the patient, isn't it? Okay. Now, the final part is prevention. Can we prevent malaria from occurrence? Of course. If we avoid mosquito bite, then malaria can be prevented. But I already told you it is easy to say but difficult to do. So, if possible, you avoid mosquitoes by limiting the exposure during times of typical blood meals, that is during dawn and dusk. So, how can we do that? By wearing long sleeved clothing and using insect repellent, okay, during that time. If you are going outside, and avoid wearing perfume and cologne because they may attract those mosquitoes towards the people, and those mosquitoes may bite them, which results in malaria. Now consider the use of chemoprophylactic agent when the people are traveling to endemic area, and these chemoprophylactic agents are available in many different forms. Okay, the different drugs like proguanil can be used, like chloroquine can be used. It depends, okay, what is the recommendation of each of the country and their respective board. Okay, thank you for the listening. Now I'll continue to upload some more videos in the next time.